Professor Bhargava. Good evening. Do you hear me?
Yes, I can hear you.
Perfect. Okay. So we have 1 minute left before starting.
Sure.
Okay. I think it's 6 p.m. at least in Paris. So we should start now. So I would like to welcome you all to this webinar from the International Society of Breast Pathology. It's the second edition of this webinar, and we are very pleased today to welcome Professor Rohit Bhargava. Rohit Bhargava is Director of Pathology and Professor of Pathology at the University of Pittsburgh, and you are the Director of the Pathology Department at Magee Women's Hospital. So it's a privilege to hear you about the Magee equation you developed with your colleagues at the Pittsburgh University. And I think that that's a major breakthrough, taking advantage of the immunohistochemistry we use in practice, in routine, as an alternative to the transcriptomic prognostic signature. And so we're going to listen to you. This webinar is registered. So please to all the participants to turn off their microphone. And we will have like 10 minutes at the end of your talk for questions. So please, Rohit, the floor is yours now.
Thank you so much, Dr. Solomon. I'm sharing my screen. Can everyone see it, or?
Yes, we do.
Okay.
It's in, yes, you have
to
swap.
Now in the presenter mode.
Thank you very much.
Thank you once again, Dr. Solomon, and good afternoon, everyone. Here are my disclosures. Some of you have heard about Magee equations before, but some of you may be hearing about it today. So for those who haven't heard about Magee equations, these are a set of multivariable models that were developed to estimate the actual oncotype DX recurrence score in invasive breast cancer. However, there is much more clinical utility of Magee equations than to just estimate the oncotype DX recurrence score, which I will go through in the later half of my talk. But before I begin, I want to provide some background about breast cancer treatment and some historical perspective. As you know, that breast cancer is a systemic disease, and it's often treated with multimodality therapy. Surgery and radiation are used as local therapy, and every breast cancer patient is offered some form of systemic therapy. And that is generally dependent on the hormone receptor profile of the cancer. For triple negative breast cancer, they are almost always offered chemotherapy. And in the neoadjuvant setting these days, chemotherapy is combined with immunotherapy. For HER2 positive disease, patients are given anti-HER2 therapy along with chemotherapy. And if they are also ER positive, they get hormonal therapy. But as you notice in this pie chart, majority of the tumors are actually ER positive and HER2 negative, 70%. And almost everyone is offered hormonal therapy. But a very small percentage of these patients, ER positive, HER2 negative, will benefit from chemotherapy. And that's really the crux of this talk and the dilemma in medical oncology as to who these patients are, how can we identify them better. For that, I think we have to go a little bit back. The historical perspective is that more than 2 decades ago, at least in the United States, this was a very authoritative document that was published in year 2000. In this NIH consensus statement, which mentioned that it is accepted practice to offer chemotherapy to most women with lymph node metastases or with primary breast cancers larger than 1 cm, both node negative and node positive. These statements were made with the best available evidence at the time. And it also mentioned decision to consider chemotherapy in node negative cancers less than 1 cm should be individualized. So that basically meant at the time that chemotherapy should be considered or given to patients with tumor size more than 1 cm. However, one critical piece of information was never considered in this NIH consensus statement. And as pathologists know that grade 1 tumors and grade 3 tumors are two very different diseases, but there was no mention of tumor grade in the NIH consensus statement. And it wasn't like the data didn't exist. Even at that time, the studies from Nottingham clearly showed that Nottingham grading is very important, and there was a very strong correlation of histologic grade with prognosis on a large number of cases. And we know that grade is prognostic even in different subgroups, less than 1 cm, 1 to 2 cm, or in tumors 2 to 5 cm, grade remains prognostic, or lymph node negative or lymph node positive subgroup. But unfortunately, grade was not included in the NIH consensus statement. So the impact of this consensus statement was that there was a substantial number of patients that were deemed eligible for systemic chemotherapy that possibly resulted in some overtreatment. And it also created a clinical need to identify patients more accurately who would benefit from chemotherapy from those who would not. Another thing that was going on around that same time was the development in molecular biology and use of gene expression profiling. Uh, in fact, breast cancer was the first solid tumor in which this particular technique was applied in the year 2000, as many of you know. Breast cancer molecular portraits were described from 2000 to 2003. Many of the seminal papers came out. Apart from the intrinsic gene set-based classification, there were many other different groups working independently, scouring the data about the genes and its correlation to prognosis, which resulted in many other different models, which were soon commercialized. And as we now know, many have these assays, 70 gene assay or 21 gene assay, have been commercialized into the multi-gene prognostic predictive assays. The two most frequently used are the 21 gene recurrence score, the Oncotype DX, or the 70 gene score, the Mammoprint. There are other less commonly used, Prosigna, Breast Cancer Index, and EndoPredict. But there have been very few studies that have done head-to-head comparison of these tests. In one particular clinical trial study, it was found that many of these multi-gene prognostic predictive marker assays categorized comparable number of tumors into low or high risk groups and or equivalent molecular subtypes, but there was only moderate agreement between tests at an individual tumor level. So depending on which test the medical oncologist has ordered, the patient could be a low risk versus high risk and maybe offered different treatment. However, for most cases, there is a moderate agreement with each other of these multi-gene prognostic assays, but it's based on limited number of studies. One aspect that is not that highlighted in these papers is that most have significant correlation with grade. And also they track a common set of biological characteristics, most prominently ER signaling and proliferation. Just taking the example of Oncotype DX, as you can see, majority of the genes, they can be grouped into three major groups: the estrogen and estrogen receptor related group, HER2 group, and the proliferation genes. And if you go back to that seminal paper in New England Journal of Medicine, you will find that the recurrence score that is calculated, the unscaled, it is heavily influenced by these three groups: the HER2 group, the ER group, and the proliferation group. The contribution of other genes is really minuscule. And we have always thought that the routine histopathologic examination, including the receptor status, should be able to predict oncotype DX recurrence score. So this was the very first time back in 2006. These findings were presented and published in 2008. That the routine histopathologic variables such as the ER, PR, HER2 status, or the H-scores, tumor grade, is predictive of oncotype DX recurrence score. And even with this small number of cases, only 42 cases, we were able to show that oncotype DX recurrence score directly correlates with the oncotype DX recurrence score, and inversely related to tumor hormone receptor content, the ER H-score or the PR H-score. H-score stands for histologic score. Some of you who are unfamiliar with the H-score is not a highly complicated thing. For example, in this particular tumor, every single cell is staining very strongly. To calculate the H-score, all you have to do is classify the cells which are completely negative, that is 0, 1 plus weak, 2 plus moderate intensity staining, and 3 plus strong intensity staining. Multiply these and add them up. So the score can range from 0 to 300. So in this case, since all the cells are strongly positive, the H-score is 300, or in other ways, you can say diffuse strong positive. In contrast, this particular tumor, there are hardly any cells with 3 plus intensity except for this one cell. So 35% of the cells are negative, 40% are staining weakly, and 25% are staining moderately. Consequently, the H-score is 90. So it's a way of semi-quantifying the results on immunohistochemistry, which can obviously be used in multi-parameter testing. So the initial study that we had was the original Magee equation. That was based only on 42 cases, but over time, we ended up sending a large number of cases from our institution for clinical testing. And we continued our QA program at the time and able to collect over 800 cases and able to note down all the pathological parameters of these tumors, namely the tumor Nottingham score, tumor size, ERH score, PRH score, HER2 status, and Ki67 proliferation index. And we wanted to improve further on the Magee equations that were originally published. So we again did the linear regression analysis to model the prediction of oncotype DX recurrence score by histopathologic and IHC variables. 3 different models were built that were based on different hypotheses and data availability. The reason I say data availability is because we were not always doing Ki67. Ki67, we started doing at our institution only in late 2007 and 2008. So not all cases had Ki67 available on the cases. So these were the 3 equations that resulted. The equation 1 had all the variables. Equation 2 had all the variables except the Ki67. And the equation 3 only had the ERH score, PRH score, HER2 status, and the Ki67. And these were developed, as I mentioned, from a data set of over 800 cases, and validation was performed on a separate set of 255 cases. The cases were categorized similar to how Oncotype was categorized at the time before the Taylor RX study. Low risk recurrence score defined as less than 18, intermediate 18 to 30, and high risk greater than or equal to 31. Concordance stats were performed between actual recurrence score and estimated recurrence score using the Magee equations, and Pearson correlation coefficients were calculated. I won't bore you with all the details from that paper. You can get that available online for free. The bottom line was that using these 3 categories, we found that Magee equations, when they estimated the oncotype DX recurrence score, the 2-step discordance was negligible. It just never happens. If the estimated score is low by Magee equations, it will never be high. And if the estimated score by Magee equation is high, the actual score will not be low. And even if it was estimated to be intermediate by Magee equations between 18 and 30, then actual score will be lower intermediate 85% of the time. So it did provide quite useful information at the time. And right after the publication, we put these out on the website for free for anyone to use. And just here is an example showing a well-differentiated invasive carcinoma with strong ER positivity, moderate PR reactivity, HER2 negative, 2 centimeter with Ki67 proliferation index of 20%, will have a score less than 18 by all three equations. So quite helpful in making clinical decisions. And a couple years later, we also had the app, which is still available on iOS devices on App Store, if someone is interested in downloading it. So correlation is good between Magee equation and the Oncotype DX recurrence score, but it's less than perfect. And we never strive for perfect here because these are two different methodologies. Oncotype is measuring mRNA levels. Magee equations are using morphologic and immunohistochemical data. And we do recognize that there can be some variability in grading or even with semi-quantification of receptor results, which can alter the results by a few points. However, there are also problems intrinsic with mRNA extraction, which is not talked about that much. That could result from suboptimal macro dissection of the tumor tissue, which could be operator related. Not all techs will do the same job similarly. Invasive tumor sometimes is intimately admixed with non-invasive tissue, and sometimes it's just not possible to separate this out. For example, here you have an invasive carcinoma right in the on the right-hand side. Then you have benign ducts, you have benign lobules, lymphoid cells around the benign lobules. All these are contributing to the mRNA that you extract from this tissue block and will alter the actual gene scores for the invasive cancers. In some cases, it can be a little bit difficult. Like here, this is LCIS involving very extensively an invasive cancer is right here, as highlighted here. So microdissecting this would be a challenge. In this one, no matter how hard you try, even using laser capture, you won't be able to separate out the tumor from the normal as the tumor cells are invading into benign lobules. So this is extremely hard. And sometimes there are things that that's a cause for major concern. In this, you can notice a DCIS, which is more grade 2 here. This is more grade 3 DCIS. And there is invasive cancer, which resembles actually the grade 2 DCIS. And this is a HER2 stain showing a IHC3+ in the DCIS, portion of the DCIS, but invasive cancer is not. So as I mentioned, like for oncotype, HER2 score heavily influences the oncotype DX score, such that even in Magee equations, it increases by 9 to 11 units. So this has the potential to give you a falsely elevated recurrence score unless the invasive carcinoma is microdissected. So that was about the development of Magee equations. But once we developed, we noticed that there were other places who started validating. So there were many external publications. We also did some of our studies leading to the development of Magee decision algorithm. And I would like to share some of those studies. We realized that even after publishing this and estimating the Oncotype DX recurrence score, we continue to send many of the cases for Oncotype DX. It didn't make much of a dent, although in the extremes of cases, the clinicians would use the Magee equations. So we thought, why not do a prospective value study to make an estimate whether it will be low risk or high risk, but do it in a prospective fashion. So in this prospective value study, we made a prediction to either send the testing or do not send the testing. Regardless of what we said, send or do not send, all cases were sent for clinical Oncotype DX testing because they were requested by the oncologist. Values were taken from the pathology reports to calculate Magee equation scores. We did not alter any of the values because we wanted to see the impact in a real world practice. The cases were labeled as do not send. if all three equations with scores less than 18, that means it's clearly a low risk case. Or all three equations with score 31 or higher, which were clearly the high risk. If any of the equations showed scores from 18 to 25, mitosis score was taken into consideration. If one, the cases were labeled as do not send. And all of the cases were labeled as send. We included 205 cases. Patients' average age was 62 years, and most of these tumors were early stage breast cancers and lymph node negative. As expected, majority of the tumors were grade 2, where the clinical decision making is a little bit challenging, HER2 negative. And out of those 205 cases, using our algorithm, we mentioned that do not send would be 146 cases, and that represents 71% of 205 cases. So we were interested in, when we made the call of do not send, does it actually turn out to be low risk or clearly high risk? So here is the table for those 146 cases. Do not send, expect low risk. 141 cases we called, and they actually came back as less than 25. There were only 2 cases we made the call, do not send, expect high risk, and they were high risk. But there were 3 cases that turned out to be discordant, what we called as do not send, expect low risk, but the actual Oncotype DX recurrence score was 26, 30, and 33. So we thought we'll take a more closer look on these. So this was the first discordant case, which was more of a mucinous type carcinoma, not only extracellular mucin, but some intracellular mucin as well. This was strongly ER positive, weak to moderate PR positive. As you can see, many of the cells are negative, but there is some staining. Ki67 was really low, less than 10%. Because Oncotype DX score was more than 25, chemotherapy was offered but declined by the patient. Patient also declined, unfortunately, the endocrine therapy. This was the second case where there is invasive cancer as well as a lot of ductal carcinoma in situ with comedonecrosis and associated calcs, and there are also inflammatory cells. Here is the invasive cancer, which is more intermediate grade, and the DCIS and some inflammatory cells. This is the HER2 stain on this case. And you can notice the invasive cancer is clearly negative, but the DCIS shows heterogeneous staining for HER2, but some areas clearly have IHC 3+ scores. So it's possible that some of this DCIS contributed to the high recurrence score in this case. And so did the proliferation rate, since the proliferation in invasive cancer wasn't as high as the proliferation in the DCIS. The third case had more micropapillary morphology, but still not very mitotically active. The actual score came back as 33, while the Magee equations estimated to be 23. And you notice that ER is quite strong, but PR is negative. And we know that PR influences the Oncotype DX recurrence score quite a bit. It also influences Magee equation scores, which are also a little bit higher, but it seems like PR contributes way more to Oncotype than to the Magee equations. And Ki67 is more of an intermediate range, slightly increased. But the thing we noted in this case was that the amount of tumor in the block that was sent was really minimal. This is a section before the Oncotype DX, the block was sent. And then we also did a recut after the block came back, and you notice that the amount of tumor is very minuscule here. And sometimes you wonder if this reactive fibrosis is contributing mostly to the score rather than the tumor itself, although there is no certain way to tell that difference. But we did Ki67, and it was a proliferative stroma. So looking back at these 3 cases, 2 of the 3 patients were offered chemo, but they either declined or it was discontinued. But the important thing is none of the patient had a distant recurrence. This particular patient who declined endocrine therapy did have a local recurrence, but which was excised and no distant recurrence 6 years later. So most of these did well, and 2 of 3 did not get chemotherapy. Based on this, we designed this Magee decision algorithm, which says that if all equations have score less than 18, then expect the oncotype DX recurrence score to be less than 25 with greater than 95% certainty. And in such cases, you do not need to send. Similarly, if all equations are 31 or higher, then expect the score to be high and you don't need to send for oncotype. If the score is between 18 and 25, look at the mitosis score. If it's 1, again, you don't need to send because the oncotype will be less than 25, more than 95% of the time. Other cases, molecular testing can be considered. So after this prospective value study, we thought we had over 2,000 cases. Why not apply the decision algorithm retrospectively? And this is exactly what we did. So of these 2,196 cases, 1,538, exactly, once again, 70% were classified as do not send. And looking at these 1,538 cases, do not send, expect low risk was 1,443 patients. And the accuracy of the do not send low risk was more than 95%. And similarly, the accuracy of do not send expect high risk was also 95%. And just like the previous prospective value study, there were some discordant cases, but instead of reviewing the slides and doing the same thing we did last time, we thought we want to look at the differences of clinical pathologic variables between concordant and discordant cases, and also look at the outcome of these cases. So looking at the clinical pathologic features of these 75 cases, we found that the only variable that was different between concordant and discordant cases was the PR status and the PR H score, which was significantly different between the two groups. And we know that PR does influence both Magee equation as well as the oncotype DX recurrence score. Lower the PR score, higher the Magee equations, and higher the oncotype score. But these 75 patients, they were estimated to be low, but were high by actual oncotype, but not everyone got chemotherapy. And that gave us an opportunity to look at the outcomes. In this case, the distant recurrence-free survival, if you look at 26 patients received only endocrine therapy, and the survival was pretty much the same, whether the patient received chemo or not chemo. So we concluded that even when the results are discordant, these patients do fine. So there is no harm done. So you can safely forego molecular testing based on the Magee decision algorithm. So let me just give you an example of how these Magee equation and Magee decision algorithm works. Just taking a hypothetical example of a 55-year-old woman with 2 centimeter grade 2 Nottingham score 6 tumor, strongly ER positive with H score of 300 and a PR negative, HER2 negative, and Ki67 proliferation index of 20%. And Magee equations are not the only models available. There are many other formulae, rules, models, nomograms, but Magee equation was the first one, and it does require more granular information. So just to give you an example, this is a University of Tennessee nomogram, which is a very nice nomogram, gives you a risk of probability of high risk oncotype and probability of low risk oncotype, but it doesn't require the more granular information like the Magee equations. And putting these parameters in there, it shows you a probability of high risk oncotype of 47% and the probability of low risk oncotype as 53%. So when you have to decide between 47 and 53%, it can be a very hard clinical decision. But once you put the same numbers in Magee equations, all equations are showing scores between 18 and 25, but the mitosis score of 1 with this Magee decision algorithm, the likelihood of actual oncotype to be 25 or less is greater than 95. So it gives you more confidence to safely forego the oncotype DX score. So cases with Magee equation scores of less than 18 or between 18 and 25 and mitosis score of 1 almost always have actual oncotype DX recurrence score of less than 25. oncotype testing on such cases lacks clinical value. An estimated 70% of clinical requests fall into such category. And if you just do the math, it has the potential to save close to $300,000 per 100 clinical test requests. So let's change gears and we'll talk about the neoadjuvant chemotherapy and Magee equations. Just a brief background about neoadjuvant chemotherapy. The systemic chemotherapy can be given before or after. Clinical trials have shown similar disease-free and overall survival, whether chemotherapy is given in the adjuvant or the neoadjuvant setting. Neoadjuvant therapy was previously reserved for locally advanced disease, but now it's frequently used in early stage cancers because you can convert patients from mastectomy to breast conserving surgery or from a bigger surgery to a smaller surgery by reducing the tumor size. That's really the primary goal. But there are additional advantages of neoadjuvant chemo. You can assess the response in vivo. You derive strong prognostic information based on residual disease. And we know that pathologic complete response after neoadjuvant chemotherapy often indicates excellent outcome. And PCR is used as an endpoint for assessing chemotherapy regimen's effectiveness, and it can also be used as an endpoint for biomarker assessment. Based on the hormone receptor status and the therapy used, the PCR rate can vary. But today our focus is on ER positive HER2 negative, and as you can see with an adriamycin, Cytoxan, and taxane-based chemotherapy, for an unselected ER positive HER2 negative tumors, the PCR rate is always less than 10%. And that's what medical oncology colleagues are always interested in, which ER positive HER2 negative tumors are the one which will benefit the most from chemo. So this is a study we published a few years ago using the neoadjuvant database at our institution, looking at ER positive HER2 negative cases and calculated the Magee equation 3 score because ME3 does not require the tumor size or the tumor grade. And as you know, in the neoadjuvant setting, when you have a core biopsy, you may not have the pathologic tumor size. The only thing available is clinical tumor size, which may not be highly accurate. And the grading sometimes can be variable on a small core biopsy specimen. So ME3 is particularly useful in this setting because it utilizes only ER, PR, HER2, and Ki67 values. We looked at the PCR rate and also the survival. And as you notice, the PCR rate in cases with ME3 score less than 18 was 0%, 4% for 18 to 31, and 31 or higher was 36%. So in the highest category, the PCR rate is quite high, almost as high as you see in triple negative breast cancer treated with ACT chemotherapy. However, you will also notice that within the same category, although it has the highest PCR, it also has the highest recurrence and death. And this happens in patients who do not achieve pathologic complete response. So it's very similar to what we see with triple negative paradox. That means triple negative tumors have the highest pathologic complete response rates to chemotherapy, but the survival is the worst because of recurrence and death in the group that have residual disease. So this was a single institutional study. So we wanted to see if multi-institutional study would make any difference or will show the same things. In this multi-institutional study, Magee cases were not included, but there were 7 different institutions, some university hospitals, some more community-based practice hospitals, and a total of 160 cases were analyzed. And by that time, Tiller RX results were published. So the cutoff points for Oncotype DX have moved. So we also looked at less than 18. We made 4 categories: less than 18, 18 to 25, 25 to less than 31, and 31 or higher. And looking at the PCR rate, it was 0% in both groups, even 18 to 25, but 14% in the more than 25, less than 31 group, and 31 or higher was 39%. And although data was not available on all cases, but in the patients with residual disease, Magee equation 3 score 25 or less had better survival, recurrence-free, and distant recurrence-free survival compared to the group that had ME3 pre-therapy score greater than 25. And there was also a trend for better overall survival and breast cancer specific survival. However, these differences were accentuated when we looked only at RCB class 3. They were all quite significant. The patients with ME3 score 25 or less clearly separates out the patients in the RCB class 3 to have much better prognosis than the ones that have ME3 score greater than 25. And I just recently noticed another paper that came out from Brazil showed almost the same thing that we had previously published. It shows the prognostic implications of Magee equation 3 and residual cancer burden in patients receiving neoadjuvant chemotherapy for hormone receptor positive HER2 negative breast cancer. What's the data out there for gene expression profiling based assays? This is a review article which gives you the PCR rate based on the oncotype scores on the pre-therapy core biopsies. And you will notice that the highest PCR reported is actually 21.4. There is also one study which shows 27.5, but that's talking about the axillary PCR. So the maximum PCR rate reported with oncotype in the high-risk group is 21.4. And when you look at the MammaPrint, this is a table listing all the studies done with MammaPrint. You see that MammaPrint highest PCR was 15%. And just summarizing the 2 or 3 studies from Magee equation 3, this is the expected PCR rate. Magee equation scores less than 18, the PCR rate is 0%. 18 to 25, it's less than 5%. 25 to 30 is 14%, and 31 or higher, it's quite high. This is almost as high as I mentioned for triple negative breast cancer treated with ACT type of chemotherapy. So it clearly shows that Magee equation 3 is similar or better than the currently existing gene expression profiling based assays. At least in the United States, endocrine therapy in the neoadjuvant setting is not used frequently. So we don't have much data on this. But this another study coming from Brazil showed that Magee equation 3 score of less than 20, that means in the opposite direction as to chemotherapy, there is a high likelihood of pathologic response to neoadjuvant endocrine therapy. This is something that needs to be further validated. So there are certain other things that can be done with Magee equations. If someone wants to implement at their own institution, obviously it will require validation, just like you bring in a new immunohistochemical stain, you have to validate. But individual institutions, if they want to use it, they have to validate in their own practice. We need more prospective studies because almost all the studies are retrospective, and inclusion of Magee equation scores in clinical trials will be very helpful to even compare when a new other molecular test comes out. Then they should be comparing with what's existing, and it would be good to compare with the Magee equations. And we need more studies on endocrine responsiveness based on Magee equations. I have presented this data at several places, and there are certain questions that come up all the time. So I thought I will include a section of frequently asked questions about Magee equations and try to answer them upfront. One question that always comes up is, which Magee equation should one use? And as I have shown that all equations generate similar results, but it's better to use all or average rather than just one if you're trying to decide about whether to send the case for molecular testing. And I say this is because look at the last 2 rows. The accuracy of do not send expect low risk is pretty much the same no matter what equation you use, or you use all equations or average, but accuracy of do not send expect high risk, that goes down if you use individual equations, but it remains quite high if you use all the equations or the average score of the equations. So that's a reason to use all of them or the average. But if you use the average, you should have all the equation results, not just that you have 2 equations and you take the average. And as I mentioned in the neoadjuvant setting, Magee equation 3 is the one which is most validated because many times grading is not possible or accurate, and the pathologic tumor size is not available. So the only equation you can use is actually the Magee equation 3, which has been validated in a number of studies to estimate the PCR rate. The other question that comes up always is, are Magee equations useful only in the resource limited or resource poor setting? There is no question that Magee equations can be extremely useful where it is cost prohibitive to perform molecular testing. However, the prediction of chemotherapy benefit using Magee equations is similar or better than any available molecular assay, so I don't see a reason why it cannot be used in the resourceful setting when it's providing you the same information or even better information. But whether it's used in the resourceful or resource limited, resource poor setting, one has to be careful doing these Magee equations that pre-analytic, analytic, and post-analytic factors should be attention should be paid to these, as these can affect the IHC results for ER, PR, HER2, Ki67, and can potentially alter the Magee equation scores. So I would strongly recommend that everyone should adhere to the ASCO-CAP guidelines, which have nice recommendations, whether you do the testing in the resourceful or resource limited or resource poor setting. Almost all of the data I have shown today or the prior studies have been done using manual estimation of the scores, the H scores, or even the Ki67, majority of them. So the question is, can automated algorithm improve Magee equations? If you compare it to an experienced and a pathologist who does the H scores very meticulously and do the counts for Ki67, then I don't think automated algorithms will show significant improvement, but there is no question automated algorithms have the potential to provide more consistent results. So there won't be a variability from one pathologist to another pathologist. So this use should be encouraged. And I think you need appropriate validation. Magee equations require H scores. So instead of just percentage of cells positive, if you are using an algorithm, try to get an H score rather than percentage positive cells, and should be evaluating the entire tumor, not just a small region of interest, because the staining can be heterogeneous. Ki67 evaluation is more amenable to automated algorithm because it doesn't require H score, it's just percentage of positive cells, but the algorithm should be able to pick up different intensities of staining. It still requires manual oversight, and all of these automated algorithms should be properly integrated in the current clinical workflow. Then the uptake by pathologists will be high. This is just to show you an example. A couple of years back, we also tried an automated Ki67 algorithm. This was one of the commercial algorithms, and this is an example where automated algorithm works perfectly. As you can see, the staining of the cells, it is color-coded as red here. This is the IHC stain, and this is on the algorithm. It's clearly picking up the positive cells, and the negative cells are stained blue. So this is working as intended. But using this automated algorithm, we did realize that sometimes the algorithm overestimated and underestimated. In this example on the top, it's not counting the cells which are negative. And in this bottom picture, you see infiltrating tumor cells clusters in the dermis, but the algorithm is counting the fibroblast in the dermis as the negative cells. So it increases the denominator, so it will be an underestimation of the Ki67 index. So sometimes you do have to pay attention, even with automated algorithms, whether it's doing its work correctly or not. And the hope is that these algorithms will improve and will be providing more consistent results. People say that Magee equations estimate the oncotype DX. What's the correlation to mammoprint? And the answer is correlation is present. There is no question, but it is not perfect. Mammoprint tends to classify slightly more cases in the high risk category now with the new cutoff points than the Magee equations. And when we apply the Magee decision algorithm to cases sent from mammoprint, 61% are classified as do not send. This is slightly lower than what happens with oncotype, where 70% of the cases are classified. They are classified as do not send when we apply the Magee decision algorithm. And also the classification accuracy of do not send expect low risk is 71%, is slightly lower or significantly lower than the oncotype, which is over 95%. But the classification accuracy of do not send expect high risk remains 100%. And this is just because with the cutoffs that are designed right now for the test, MemmaPrint tends to classify slightly more cases in the high risk category. Just to understand more, these are the MemmaPrint have recently started even dividing their low risk and high risk into two groups of each, ultra low, low, MemmaPrint high 1 and high 2. So essentially creating 4 different categories. And since there were 4 different categories, we have looked at how they compare to the 4 categories of Magee equations. And is there a correlation? So looking at this table, we had 365 cases that were sent for MemmaPrint, but we had MP index available on 277. And as you can see, the average MP index, if I go back, the positive ones indicates low risk. That's +1 is the lowest risk and the -1 is the highest risk. And if you look here, the average MP index is in the positive category in the 0 to 18 category. Within 18 to 25 is just crosses the border of 0. And the interquartile range is in both positive and the negative territory. Greater than 25, less than 21, ME score goes into the negative category. That means MP is in the high risk. And then 31 or higher, obviously it starts going closer to -1. And then interquartile range, you will see it's -0.7. So there is a correlation. And if you look at different categories, this is how they separate out. When Magee equations scores are 0 to less than 18, you do not see an ultra high risk cases. They only start to appear when Magee equation goes to 18 to 25 and significantly increase when Magee equation scores are 31 or higher. And if you reverse this such that Magee equations are plotted on the y-axis and MemmaPrint categories here, you see the opposite. In the ultra low risk MemmaPrint, the only cases which are there are actually all Magee equations score less than 25. And they start to appear only when we go from low to high to ultra high, where they form significant numbers of 31 or higher. So there is a correlation. Obviously, there are different tests and they are measuring different things, but correlation is present. The final question is, are Magee equations prognostic or predictive? And the answer is probably both. Like just all other models, data is limited on the prognostic value and harder to study outside of a clinical trial. That's why very little data exists on the prognostic value, because it requires untreated and homogeneously treated patients matched for other variables. And predictive value, as I've shown, it has been shown multiple times in the neoadjuvant setting. But I want to share this particular piece of data. This was a study we did on lobular-like invasive mammary carcinomas and compared them with invasive ductal and invasive lobular cancers. And in this study, only grade 1 and 2 tumors were included. So there are no grade 3 tumors. And as you can see, the prognostic value of Magee equation 2, because we didn't have Ki-67 on these cases, these were old cases, when the score is less than 18, these have excellent survival compared to tumors that have scores more than 18. So it seems like it does have a prognostic value as well. And most of the tests have both prognostic and predictive value. And depending on where you draw the cutoff point of low risk and high risk, it can be slightly more prognostic or slightly more predictive. The way I look at it is that with Magee equation, if you draw the cutoff at 25, it becomes slightly more predictive, just like the Oncotype DX score. And if MemmaPrint, the cutoff is created at 0, then it's more prognostic than predictive. If you make the cutoff at high risk or ultra high risk, then MemmaPrint will become more predictive. This is an interesting study I would like to share, where the authors asked the question, does integration of Magee equations into routine clinical practice affect whether oncologists order Oncotype DX test? And they concluded that in a practice where Ki-67 is routinely available, addition of Magee equations was not associated with the reduction in oncotype DX use. However, availability of both Ki and Magee equation did, however, increase physician comfort with systemic therapy decision. I think I want to bring a very important point. Many people think, or many oncologists have this view that high Ki-67 means response to chemotherapy. And I just like to say that Ki-67 alone may not be the best predictor for chemotherapy response, because ER-positive, HER2-negative tumors, the response to chemotherapy is highest with high Ki only when there is a concomitant reduction in hormone receptor content. So ER and PR H-score values have to go down for the best response with high Ki, because there are tumors which have high Ki but also high ER and PR H-scores. They don't respond as well to tumors that have lower ER and PR H-scores. Just to keep something in mind, and because Magee equations uses both ER, PR H-scores and Ki-67, it provides you a better predictive tool than Ki-67 alone. So in summary, all Magee equations provide a reasonable estimate of the actual recurrence score. These are user-friendly, available on the web. Cases with unexpected results should be carefully reevaluated using a team approach. Magee equations appear to have prognostic and chemopredictive value. The indiscriminate use of expensive molecular testing can be curtailed by using equations in everyday practice. I would like to acknowledge some key individuals, Dr. Melina Flanagan, who published the first paper on Magee equations, Dr. David Dabbs, with whom I worked for several years here at Magee, Yongli Shuai, the biostatistician who helped us tremendously with the regression equations, Mr. Tom Harper, who developed the web page, and so that the Magee equations could be offered to everyone for free. The breast cancer patients who sought treatment at our hospital, highly indebted to them, our clinical colleagues and collaborators, the UPMC laboratory, and last but not the least, the Magee pathologists, my colleagues, who have meticulously worked on providing the H-scores and the Ki-67 proliferation index on every breast cancer newly diagnosed here at Magee, without which none of this was possible. Thank you very much, and I'll be happy to take any questions.
Thank you so much. So, yes, I think that the reactions are really great. So I think that we have time for questions.